Bismillahirrahmanirrahim. Assalamu alaikum everyone. I hope everyone's Ramadan will be going very well. You people will be trying to balance your studies and your ibadah so regularly and with your concerns of last week regarding PowerPoints lectures that you people were having problem in going through the PPTs. So we decided to upload recorded audios of our lectures from this week, and I hope it will maximize your learning. And regarding this, we will need your feedback that how it has been fruitful for you, and if you have any other suggestions regarding it, you are most welcome, and we will try to incorporate it for your more maximum learning. So beginning with the name of Allah, the most gracious, the most merciful, with prayer to Allah to increase our knowledge. We have a case scenario. A 1-year-old child is brought to the emergency room with complaint of fever and several episodes of loose motions since morning. On examination, he is lethargic, eyes are sunken, and skin turgor is reduced. Temperature is 100 degree Fahrenheit. So what do you think is the diagnosis of this patient, and how will you manage this patient? Well, I guess most of you would have got the diagnosis. Yes, it is a baby suffering from diarrhea. So today is our topic is on anti-diarrheal drugs. This is the most common. Most of you would have been suffered from it throughout your life, or any other person in your family. So this is a very common, a very important topic, and we should be aware of the what are the drugs can be used to treat the diarrhea. So coming to the its learning outcome, at the end of this lecture, all of you should be able to manage a patient suffering from diarrhea. And moving forward to the learning objectives of this lecture, all of you should be able to define and differentiate different types of diarrhea, and then classify different antidiarrheal agents, discuss the mechanism of action, uses, adverse effects, and contraindication of different antidiarrheal agents, that anti-motility agents, adsorbents, agents that modify fluid and electrolyte transport, alpha-2 adrenergic receptor agonist, which you have studied in your autonomic nervous systems. We will recall it here too, and then appraise the role of ORS, antimicrobials, probiotics, and zinc supplements in treatment of diarrhea. So coming to the diarrhea, well, diarrhea is defined by World Health Organization as having 3 or more loose or liquid stools per day, or as having more stools than is normal for that person. Well, it refers to increased frequency of stool which are loose or watery in nature. Let's recall first the physiology of the gut, that how it works, what were the basic mechanisms, so we could have idea that how the diarrhea occurs, and then we can learn how we can control the diarrhea, or what the drugs are available to control diarrhea. Well, as we know that GIT is in a continuous state of contraction, absorption, and secretion, and this control is highly complex. It is contributed by muscle itself, the enteric nervous system, and the central nervous system, and the humoral pathways, which include the hormones, GI hormones, and they all are basically controlling the gut motility. And among all of these, the most important regulator is the enteric nervous system. And what is that? It is the autonomous collection of nerves within the wall of the GIT. And it comprises of 2 plexuses. The one is the myenteric plexus, which is basically located between longitudinal muscle of the gut and the circular muscle of the gut, and it controls the motor control of the GIT. It's basically the motility of the gut is controlled with the help of this myenteric plexus. And the second plexus we have is the submucosal plexus, or we can also name it as deep muscular plexus. It is situated between the circular muscle and with muscularis mucosa, and it basically regulates the secretions, fluid transport, and vascular flow. It's just a recall. You must have gone through these in detail in other lectures too. So And now, moving forward to the types of diarrhea, basically they are broadly differentiated into acute and chronic diarrhea. How you will label if someone having diarrhea, that is he is having acute or he is having chronic diarrhea? It's very simple. If a person is having diarrheal episodes occurring for less than 2 weeks, then that person is having acute diarrhea. And if it is more than 2 weeks, that will be chronic diarrhea. While talking about the acute diarrhea, it is most often caused by a wide variety of infectious diseases of small and large intestines. Suppose if someone's having food poisoning, or someone got typhoid fever by salmonella typhi, if someone got cholera due to Vibrio cholera, or someone amoebic colitis due to Entamoeba histolytica. So moving forward to the chronic diarrhea, as we mentioned before also, that if the diarrhea episodes occur for greater than 2 weeks, we label it as chronic diarrhea. And digging out the causes of the chronic diarrhea, it could be the colonic cause, it could be the malabsorption, or it could be due to small bowel disease. And if it is due to some small bowel disease, it will be further classified into Crohn's disease or ulcerative colitis. Suppose if a person is having Crohn's disease, then it is basically a chronic inflammatory disorder, and it classically affects the terminal ileum of the gut. And if a person is having ulcerative colitis, then it is a chronic, relapsing and remitting disease, and in it there is diffuse superficial ulceration of colon. And in both of these conditions, basically the nutrients and electrolytes are not able to be reabsorbed properly, either in the ileum or in the colon, and they are basically excreting out from the body at higher frequency. So coming to the other causes, it could be due to some drugs. Some drugs can lead to the irritation of the gut and can cause the diarrhea, or it could be some drugs like antibiotics. They kill the healthy microflora of the gut, and due to that, it could lead to the overgrowth of some harmful bacteria and can lead to superinfection and then finally diarrhea. And it could be also due to some emotional states, like some people have diarrhea in stress anxiety conditions. And the other cause could be if traveler's diarrhea, if someone is going on a journey and that person can get the traveler's diarrhea. So if we are going to have a touch of the etiology, it could be if someone is having the infective diarrhea, it could be caused by enterotoxigenic and enteroinvasive organisms. You must have studied this more in detail in your pathology. And the non-infective diarrhea could be due to many reasons. So now coming to the treatment approaches of severe acute diarrhea. So, very first step in any case of diarrhea, what would be, you will rehydrate the patient. The first step is rehydration. That is replacement and maintenance of fluid and electrolyte balance after appropriate assessment of dehydration. You will go to the wards. They will teach you how to diagnose the mild dehydration, moderate dehydration, severe dehydration by doing skin pinch and then releasing it. And what do we use in rehydration? We basically use ringer lactate or normal saline through oral route if a person is having mild diarrhea or moderate diarrhea, and through IV route if a person is having severe diarrhea. So after rehydrating the patient, the second step will be the drug therapy. uh, we can go on the we have two options. One is the non-specific anti-diarrheal drugs if the person is having non-infective diarrhea, and we can use the specific antimicrobial drugs if a person is having infective diarrhea due to some pathogen, if the person suffering from diarrhea. And the third treatment approach will be the maintenance of nutrition. So you need to counsel the patient, you advise the patient to take soft diet, and especially KYB, that stands for khichdi, yogurt, and banana. It is really helpful in decreasing the episodes of the diarrhea. So as we talked in previous slides, the first step was of the rehydration. So in the rehydration, we mostly use the ORS, or is the oral rehydration salt. And WHO and UNICEF recommended formulation is We will discuss this formulation. Now, first of all, I want to tell you about the original ORS and the low osmolarity ORS. Basically, this low osmolarity ORS is a new version of the original ORS, and it has a better safety profile, especially in children, and it has better outcomes. So it is now more preferred in children, low osmolarity ORS. So coming to its composition, original ORS will have anhydrous glucose 20 gram, and low osmolarity ORS will have 13.5. Similarly, sodium chloride original ORS will be have 3.5 gram per liter, and it will be reduced in low osmolarity ORS. It will be 2.6 gram per liter. Whereas the composition of trisodium citrate and potassium chloride is similar in both of the ORS. Only the difference comes in the glucose and sodium chloride. Like trisodium citrate is 2.9 gram per liter, and potassium chloride is 1.5 gram per liter. So you can memorize the composition of ORS, and it will be helpful for you, and it will be helpful for you regarding your auspice too. It can come in your auspice, and so coming more to the uses of the antidiarrheal agents. Uh, these may be used safely in patients with mild to moderate acute diarrhea, and they're also used to control chronic diarrhea caused by conditions like irritable bowel syndrome or inflammatory bowel disease. Our next lecture is on this. Basically, antidiarrheal agents too will be on the drugs used for IBS and IBD. So we can use these antidiarrheal agents in those conditions too. But these agents should not be used in patients with bloody diarrhea, or patient having high fever, or if there is some systemic toxicity, because of the risk of worsening the underlying condition. Coming to the classification of antidiarrheal agents, basically broadly we classify the antidiarrheal agents into non-specific antidiarrheal agents, and then we have specific antimicrobial agents. So talking about the non-specific antidiarrheal agents, the first one we have is the anti-motility agents. So as it is self-explanatory that these agents will prolong the intestinal transit time by reducing the gut motility. In these we have the first group we have is the naturally occurring opium alkaloids, which includes morphine and codeine phosphate. The second group we have synthetic opioid compounds, which we have diphenoxylate, lixadoline, and loperamide. Third group we have the antimuscarinics. You are very familiar with it. You have studied it in autonomic nervous system, and it includes atropine, propanthyline, dicyclomine, and hyoscyamin. And how they are going to do, as you already know, that antimuscarinics on the gut will have effects like they will decrease the motility of the gut, and that what you want in the diarrhea. Then moving forward in the classification, the second group we have the adsorbents, and adsorbents is also a self-explanatory word. What the adsorbents will do, they will basically absorb the excessive fluid from the gut and decrease the liquidity of the stools. In adsorbents, we have different compounds like kaolin, attapulgite, pectin, methylcellulose, calcium polycarboxyl, and spogolhas. I'm sure most of you will be having this in your homes. The third group we have in the non-specific antidiarrheal agents is the agents that modify fluid and electrolyte transport, that we want to reabsorb the more of the fluid from the gut, reabsorb the electrolytes. In that we have bismuth subsalicylate and bile salt binding resins, octreotide. And then we have another group that is, and you're also familiar with this group, that is the alpha-2 adrenergic receptor agonist. In that we have clonidine. You have studied before in your ANS, in your antihypertensive agents, and it is also used as an antidiarrheal drug. And then we have another category, that is the antimicrobial agents, which are used for the infective diarrhea. And we have another compound, that is the probiotics. They are very useful in the diarrhea. In the case, especially for example, if it's antibiotic associated diarrhea in which there have been healthy flora of the gut have been killed by the antibiotics, then it can help to regain to regrow that healthy flora of the gut by giving probiotics. And similarly, zinc supplements, they are also very helpful, especially in children, to decreasing the episodes of the diarrhea. That was the classification of anti-diarrheal agents. So coming to the details of individual groups, we'll begin with the anti-motility agents. Now the anti-motility agents, basically the first we had the opioid agonist, and you have already studied opioid in your CNS also in detail. So the opioids which we use as antidiarrheal agents here, they are the diphenoxylate, loperamide, alloxidone. First, we will discuss the mechanism of action of these opioid agonists. Basically, what they do, they cause the inhibition of presynaptic cholinergic nerves. Here you can see that agonist is binding with the opioid receptor, and it is basically inhibiting the adenyl cyclase. Similarly, it's inhibiting the calcium release, and it is inhibiting the decreasing the release of the neurotransmitter. So there is presynaptic inhibition of cholinergic nerves in submucosal myenteric plexus is occurring. So it's leading to increased clonic transit time, and it decreasing the secretions and causing fecal water absorption. So what will happen, it will increase the tone of the gut, and it will decrease the propulsive activity of the large intestine, right? So what else it's do, if for the first one is that it's having it is inhibiting the it is doing presynaptic inhibition of cholinergic nerves in the myenteric and mesenteric plexus. The second one is a point of mechanism of action is that it is decreasing the mass colonic movements and gastrocolic reflex. So by these two ways, it is acting as an anti-motility agent. And all opioids have anti-diarrheal effects, CNS effects, and so there is potential for addiction. So this is the reason it limits its usefulness here for most of the time. So coming to now diphenoxylate, and details of diphenoxylate, which is anti-motility agents. Well, it does not have morphine-like activity in CNS, but at higher doses, it has CNS effects, and can prolonged use can lead to opioid dependence. So what is the solution of it? If we want to have an anti-diarrheal effect and we don't want to have opioid dependence or CNS effects, what we have done, basically we have made the commercial preparations with the name of Lomotil. And what are those preparations? Basically, it contains the diphenoxylate, for example, 2.5 milligram, along with the atropine in 0.025 milligram. What will be the advantage of it? The advantage will be this, that atropine will itself act as anticholinergic or antimuscarinic effect, which will lead to antidiarrheal action. Secondly, small amounts of diphenoxylate will be required to produce the antidiarrheal effect, or right. So it will decrease the CNF effects or opioid dependence. This is the reason. So I hope you got it. Now moving to our next drug, that is the loperamide, and it's also known as Imodium. It's a non-prescription opioid agonist. You can get it from pharmacy without any prescription, and it does not cross blood-brain barrier, and it has no analgesic properties or potential for addiction. And the dosage is 2 milligram 1 to 4 times daily. You can prescribe it to the patient. So moving forward to the next drugs we have is the alloxidone. It is a prescription opioid agonist, and it has high affinity for mu receptor and low affinity for delta receptors. And what it does, it results in slower colonic transit, and it increases fecal fluid absorption. Where do we use it? We basically use it in a patient of irritable bowel syndrome, which we'll discuss in details in our next lecture. And as I will just tell you briefly about its IBS, that in irritable bowel syndrome, basically patients have diarrhea alternating with constipation. So this drug will be used in those patients which have predominant diarrhea as compared to constipation. So we can use luxadolin in those patients. Dose will be 75 to 100 milligram BD. Now talking about its adverse effects, as we say that it increases the water reabsorption. So what do you think what can happen? It can lead to constipation. And secondly, it causes the spasm of the sphincter of Oddi. It can lead to pancreatitis. So due to these adverse effects, it is contraindicated in patients having history of pancreatitis, alcoholism, or known sphincter of Oddi diseases. And we need to exercise caution for patients who have undergone polycysectomy, and because it causes the spasm of sphincterodia, so therefore we need to give them a lower dose, that is only 75 milligram. Now moving forward to our next group of drugs, that was adsorbents. As we discussed it before too, that they basically absorb water. So basically these are colloidal bulk forming substances which absorb water and swell, and they modify consistency and frequency of stools and give an impression of improvement. Adsorbents main preparation we have already seen in the classification 2, that is kaolin, pectin, carboxymethyl cellulose, calcium polycarboxyl, and sphingolase. And discussing regarding kaolin, basically clays such as kaolin, which is a hydrated aluminum silicate, and attapulgite, which is a magnesium aluminum disilicate. What they do, they basically bind water avidly, and along with the water, they can also bind with the enterotoxins which are present in the gut. Secondly, we have the pectin. Basically, it is an indigestible carbohydrate and it is derived from the apples. Both kaolin and pectin act as adsorbents of bacteria, toxins, and fluids, and they decreases stool liquidity and frequency. We use it in acute but not in a chronic diarrhea. Doses 1.2 to 1.5 gram after each loose stool, and maximum 9 gram per day can be advised, not more than that. And there are some preparations of kaolin and pectin available, and they are not absorbed, and so they have no significant adverse effects except that is constipation and binding with medicine. So we don't need to give them with other medicines. And coming to our other adsorbents, they are the carboxymethyl cellulose and calcium polycarboxyl. They also absorb water and increase stool bulk, and the calcium polycarboxyl absorbs 60 times its weight in water. Now coming to our the common drug is alcohol husk, which I'm sure will be in most of your homes. Now the interesting thing about this alcohol husk is this, that it can be used in diarrhea as well as constipation. Now you will thinking, how is it possible that we can use the same thing for the both conditions? Basically, the difference comes in its use. Suppose if you are going to use it with the for the diarrhea, what you will do, you will use this small husk with the minimum amount of water, that as we take, suppose आप ज़मान में आपका कि आप फक्की जैसे डालते हैं और पानी पी लेते हैं, right? So you need to take a little amount of water with this for the treatment of the diarrhea. But if you are going to take it for constipation, what you have to do, you have to take it with an ample amount of water, with like full glass of water, or you need to take it with a warm milk. Okay, it will resolve the constipation. So the difference comes in the how do you use it. In the diarrhea, you use it with minimum amount of water, and in the constipation, you use with a bulk amount of water, with more water. So it basically causes osmotic pressure and it relieves the constipation. And whereas if you take it for the diarrhea with minimum amount of water, and then it goes in the gut, and so it has basically absorbs the fluid, which is excessive fluid which is present in the gut. So that was a little detail of the Swagalhas. We'll move forward in our lecture. The third agent we have, that is the agents that modify fluid and electrolyte transport. Again, and these agents will try to reabsorb maximum fluid and electrolyte and resolve the diarrhea. The first drug we have is the bismuth subsalicylate. It contains bismuth and salicylate. It dissociates rapidly in the stomach, allowing absorption of salicylate. Salicylate, what it does, it absorbs and it inhibits intestinal prostaglandins and chloride secretions. So, if the prostaglandins are not secreted, chloride is not secreted, it will reduce the stool frequency and liquidity in acute infectious diarrhea. So, where do we use it? We use it for the traverse diarrhea, and it has direct antimicrobial effects, and it binds enterotoxins, accounting for its benefit in preventing and treating traverse diarrhea. Well, discussing regarding its adverse effects, it has adverse effects of harmless blackening of stools, and its liquid preparations causes harmless darkening of tongue. So you need to advise your patients while you are prescribing this drug that such sort of adverse effects will come, and you don't need to worry about it. You need to counsel your patient. And salicylate toxicity can also occur at higher doses. So now coming to our next groups of agents that modify fluid and electrolyte transport, they are the bile salt binding resins, and there are three drugs we have: cholestyramine, cholestyramine, and cholestyramine. Basically, what happens that 95% of bile salts are reabsorbed normally in intestinal capillaries in the terminal ileum, right? But if there is some disease, suppose there's some Crohn's disease of the terminal ileum, then these bile salts are not reabsorbed through enterohepatic circulation, and it leads to malabsorption of bile salts, and it leads to then colonic secretory diarrhea. So we have a group of drugs. What it will do that it will bind these bile salts, and it will not let it be excreted along with the feces and leading to secretory diarrhea. So in these drugs, cholestyramine, 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 they bind bile acids in intestinal lumen, and they prevent excess fecal loss of bile acids. The usual dose is 4 to 5 gram OD2 TDS before meals. Talking about the adverse effects of these bile salt binding resins, they can lead to bloating, flatulence, constipation, and fecal impaction. Obviously, they're going to reabsorb the bile salt, reabsorb the fluid, can lead to all these adverse effects. And in patients with diminished circulating bile acid pools, further removal of bile acids, as they are doing it, they're reabsorbing bile acids, it may lead to an exacerbation of fat malabsorption, because we know that bile salts are essential for the fat emulsification. So these bile salts are, as previously they were not reabsorbed by enterohepatic circulation, they were lost in the feces, and fats. So fats were not emulsified; they would have been lost along with the feces. Now, when we are giving these bile salt binding resins, they are again to be bind with these drugs, so they are not available for the fat to get emulsified and to get reabsorbed, and so fat will get excreted in the stool, and it would lead to steatorrhea, and it can lead to fat soluble vitamin deficiencies. So, and among these three, there is cholestyramine and cholestyramine. It also reduces the absorption of other drugs. So, what we should do, we should not advise these two drugs along with the administration of other drugs. There should be at least a lap of 2 hours. Now, coming to our third drug, that is octreotide. Now, before discussing octreotide, we should have a small little discussion regarding a somatostatin. Basically, octreotide is a synthetic analog of somatostatin. First of all, we should a little bit brief about the somatostatin. Basically, it is a inhibiting hormone which is secreted from the GIT, from the hypothalamus, from the pancreas. What this hormone does, basically, it's an inhibitory actions on the gut, motility, on the pancreatic secretions, gut secretions, and it reduces the portal blood flow. And but the main thing is it reduces the secretion of insulin, glucagon, growth hormone. But the shortcoming with this hormone is this that it has half life of only 1 to 3 minutes. So therefore, we designed a synthetic analog which has a more half-life of around 3 hours, 1 to 3 hours, and it is 45 times more potent than somatostatin. So what it will do, it inhibits the intestinal pancreatic secretions. It will decrease the GI motility. It will inhibit the gallbladder contractions, which is the purpose we want, that we want to decrease the GI motility in diarrhea. So talking about the uses of octreotide, basically these octreotide is used to treat secretory diarrhea in some GI tumors, for example, carcinoid tumor, vicoma, or some advanced symptomatic tumors that cannot be completely removed by surgery. In such GI tumors where there is secretory diarrhea, we can use the octreotide. Octreotide will decrease its secretions of the gut, and it will decrease the secretory diarrhea. Similarly, uh, uh, moving forward regarding effects of the octreotide or its uses, well, it has dose-related effects on bowel motility. In lower doses, basically, it stimulates the gut motility, whereas in higher doses, it inhibits the motility. So if you want to give it as antidiarrheal agent, we will give it in higher doses, because in higher doses it will inhibit the motility. And higher doses are also used for the treatment of diarrhea due to vagotomy. Vagotomy, that there is some vagus nerve is cut, or dumping syndrome, or due to short bowel syndrome or AIDS. In all these conditions leading to diarrhea, we can use the octreotide. So moving forward regarding the uses of octreotides, as we discussed, that low doses decreases the gut motility, and higher doses basically inhibit the gut motility. So we can use the low doses like 50 micrograms of potency to stimulate small bowel motility in patients with small bowel bacterial overgrowth or intestinal pseudo obstruction secondary to scleroderma. So we can employ the use of octreotide in low doses in these conditions. And we can also use octreotide in pancreatic fistula because it inhibits the pancreatic secretions. And we can also use octreotide in gastrointestinal bleeding because, as we discussed also before, that it reduces the portal blood flow. So we can use it in the gastrointestinal bleeding. Discussing regarding the adverse effects of the octreotide, it can lead to cysturia, leading to deficiency of fat-soluble vitamins, and because it is why it's leading to cysturia, because it is inhibiting the gallbladder secretions, okay, pancreatic secretions, and both of these are necessary to for the fat digestion, and so it leads to cysturia and ultimately leads to deficiency of fat soluble vitamins. And it can lead to nausea, abdominal pain, and it can lead to formation of gallstones and really acute cholecystitis, because the gallbladder is not able to contract and the hormones are going to retain there. It can lead to gallstones formation, and ultimately it can lead to acute cholecystitis. It can lead to bradycardia, hypothyroidism, and as we discussed, that octreotide decreases or it disturbs the release of the glucagon, insulin growth hormone. So therefore, it can lead to sometimes hyperglycemia and less frequently hypoglycemia. Now coming to our and the next group, that is the alpha 2 adrenergic receptor agonists. As I told you, you have discussed we detail in the ANS and in the antihypertensive agents. So basically what it does, it acts on the clonidine alpha 2 receptors, and it causes presynaptic inhibition. So it is used in diabetic patients with chronic diarrhea in whom autonomic neuropathy occurs and can lead to loss of noradrenergic innervation. तो डायबिटिक पेशेंट्स के अंदर बेसिकली हम यूज करते हैं जिनमें ऑटोनॉमिक न्यूरोपैथी हुई होती है, ठीक है. सो for those with diabetics treating the chronic diarrhea, we can use clonidine, and it is also useful in patients with diarrhea caused by opioid withdrawal, because as we know that opioids usually causes constipation if there is some patients on opioid and also withdraw can lead to diarrhea. You can use the clonidine. The dose is 0.1 milligram BT. Now coming to side effects of the hypotension, as we just, it causes hypotension. Why it will lead to hypertension? Because it acts on the alpha 2 receptor presynaptically, so neurotransmitters will not be released, and the normal regulatory mechanism of the blood pressure control, it will be disturbed and will lead to hypertension. Similarly goes for the depression. Why the depression will occur? Because it causes a presynaptic inhibition of the neurotransmitter release, so the hormones will not, deficiency of the hormones will lead to the depression and then fatigue also. Now are coming to next major group, which was the antimicrobial agents. Till now we have discussed the agents, non-specific antidiarrheal agents, which were used for the non-infective diarrhea. Now we are going to discuss drugs which are the antimicrobial agents and which are used especially for the infective diarrhea or diarrhea due to some microbes. So infective diarrhea patients can generally be placed in one of the two categories. Number one category will be patient will be having abundant watery diarrhea but lacking mucus or blood, and usually dehydrating with frequent vomiting but little or no fever. There will be no sign of fever infection. There will be no mucus or blood in the diarrhea. So what we are going to do, we can advise the patient ORS, and not antimicrobials are the main therapy here. But in the second category, suppose if patients having loose, smaller volume stools frequently with mucus or blood or mild dehydration, usually it attended with fever and abdominal pain but not vomiting, antimicrobials will be needed here in these, because this is most probably infective diarrhea. So antimicrobials are no value in diarrhea due to non-infective causes such as irritable bowel syndrome, diarrhea due to celiac diseases, diarrhea due to pancreatic enzyme deficiency, diarrhea due to thyroid toxic. We don't use antimicrobials here. Where do we use? We can use one of the conditions also is rotavirus, which is especially more common in the children in developed countries. It's the most important pathogen of acute diarrhea, and we can use the although it is a virus, but we can use the antimicrobial, and we've successfully seen the suffixing being used for the children and adults with diarrhea having a rotavirus. So antimicrobials are regularly useful in cholera, Campylobacter jejuni, Clostridium difficile infection. Similarly, can be used for giardiasis. Here we will use metronidazole. And if diarrhea is associated with bacterial growth in blind loops or diverticulitis, it may be treated with tetracycline or metronidazole. And if it is due to diarrhea is due to amoebiasis, we can use the dialysate furoate and metronidazole. So this is a chart basically showing you if the diarrhea is due to some Shigella species, what will be the preferred drug? We can use the ciprofloxacin, 500 milligram BD for 5 days, and we have the alternative drugs, ofloxacin, ampicillin, cotrimoxazole. Similarly, if it's salmonella, suppose the patient is having typhoid or having diarrhea, or suppose if diarrhea is due to salmonella species, we can advise patient preferred drug will be ciprofloxacin, 500 milligram BD for 10 days. And then the alternative drugs, we have ceftriaxone. Sometimes this ceftriaxone is alternate, is also preferred drug if a patient having severe infection. So the other drugs we have alternative ceftriaxone, ofloxacin, and levofloxacin. Similarly, then we have Campylobacter jejuni. We can use ciprofloxacin 500 milligram BT, and alternative drugs erythromycin, doxycycline. For Vibrio cholera, patient having cholera can use doxycycline 100 milligram BD for 5 days. Ordinary drug is ciprofloxacin. Similar for E. coli, we have Cipro 500 milligram BD for 5 days. Or alternative is cotrimoxazole. Similarly, if it organism is Clostridium difficile, then metronidazole can be advised, and alternative drug is vancomycin. If the organism entamoeba then we can advise metronidazole 400 milligram TTS along with the dihydrogenate fumarate 500 milligram TTS for 7 days. Alternative drug is tinidazole. If it is due to Giardia lamblia, then we can advise the metronidazole 200 milligram TTS for 5 days, and alternative drugs are tinidazole, paramomycin, and dazoxanide. So moving forward to the probiotics. As we said, the probiotics are very useful, and they are the preparations containing a variety of bacterial strains, and they benefit in acute diarrheal conditions. Antibiotic associated diarrhea, as I discussed with you before, that if antibiotic is the healthy flora of the gut, then these probiotics basically will replace those diet healthy microflora. And we can also use probiotics in infectious diarrhea. I tell you my personal experience that as is saying, they are written in German. I guess if my kids are going to have a diarrhea and they are not having fever, literally I just at the first attempt I give them these ampoules, and literally if it is non-infective and it is mild diarrhea, it resolves with these entire German ampoules. So they are very effective. For the kids, we have these in ampoules form, and they might be available the tablets for the adults, or adults can also take this. It's very useful. And then next, otherwise, as we probiotics is also present in the yogurt in the nutrition, and we take the yogurt, it was also a part of probiotic. That's why we advise the yogurt in diarrhea. Then we have zinc supplements. They are very useful, especially for the children. Zinc supplements for the children in the syrup form, or for the adults, they are also in tablets form. What does the zinc do? Basically, it's a vital micronutrient. It is very essential for protein synthesis, cell growth, and differentiation. And uh, it betters the immune function, and it is a vital micronutrient for intestinal transport of water and electrolytes. So it regulates the water and electrolyte transport, and it betters the immune function, and it causes the protein synthesis, cell growth, and differentiation of the intestinal cells of mucosa, which are being shed off in the acute diarrheal states in increased frequency. So they are very helpful, these supplements. So coming last step was the maintenance of nutrition. As we already know that in the diarrhea, either it be children or it be adults, they start to starve, that we don't want to eat because we have diarrhea. That is very wrong. We should counsel the patients, as adults or the children, to take simple food, soft diet. And if it is a baby or small, we can advise the breast milk or half strength buffalo milk, boiled potato, rice, chicken soup, etc. should be given as soon as patient can eat. And I mentioned you before the KYB diet, which we used to prescribe when I was doing my house job in the diarrhea unit. I have 1 month preparation, and we used to daily prescribe on our prescription for the and writing out these KYB diet, and that means khichdi, yogurt, banana. It's preferred in diarrhea. So anyone having diarrhea, either adult or a children, they should try to have this diet in the diarrhea. It really resolves diarrhea soon. So I have a question MCQ here, which I have also given you in assignments. You will attempt that there. Well, a 2-year-old child presented to OPD with complaint of blackening of stool and mild discoloration of skin and tongue. His mother used to give him an anti-diarrheal agent on recurrent episodes of diarrhea. So which of the following anti-diarrheal agent was given to the child? Atropine sulfate, bismuth salicylate, phosphalum, carboxymethyl cellulose. So you're going to answer this MCQ on your assignment, and I have 2 other MCQs given in your assignments. You need to do your assignment within 24 hours and submit it back. And these were my learning resources: Gadsden, Goodman, Gilman, Lipin. And last, I will end up my lecture with food for your thought. That is, don't give up. The beginning is always the hardest. So believe in yourself. And I will end with thanks to you, Jazakallah khair, and with lots of prayers and good luck to you. Thank you.